Good evening and welcome to the Portsmouth Athenaeum, a nonprofit membership library incorporated in 1817. I am the keeper, Tom Hardiman. We may have some guests with us from our sister libraries in the membership library group, which is the 20 remaining libraries in America that are funded solely by their members. Our presenters this evening are Elizabeth Howard and Charles Vidich. Elizabeth is an author, journalist, creative director, and is now the host of the Short Fuse podcast, which is produced by the Arts Fuse of Boston, an online arts culture journal covering dance, film, art, music, and theater. She is a proprietor of the Athenaeum, and her proprietorship comes through her uncle Jim, who is James Millar. And he purchased share number 62 in 1979, and that was after it had just been given up by the estate of Ogden Nash. So it's quite a revered share. Charles Vidich is the author of Germs at Bay, Politics, Public Health, and American Quarantine, which he will be discussing with us today. Charles is a consultant and advisor on public health and bioterrorism issues. He was appointed a visiting scientist at the Harvard School of Public Health, working for 10 years on national quarantine policy. So he is not a newcomer to this by any means. He has many accolades to his resume, and hopefully he'll be informing us all tonight about the history of quarantining in America. Just one little note that we've already discussed is that we're going to ask that you stay muted and hold questions to the end of our presentation, or type them in the chat so that we can refer to them later.
Tom, thank you. It is really lovely to be with all of you at the Athenaeum. And as Tom mentioned, my Uncle Jim was a member for almost 20 years and loved Athenaeum. I believe he was the treasurer for a while. And I think when he retired, he took up painting, which kind of surprised me. And I know he spent lots of his voracious reader. And I think he spent a lot of afternoons reading at the Athenaeum. So it's really a privilege for me to kind of carry on that, his special proprietorship. Charles, it's lovely to be here with you in conversation around Germs at Bay, politics, public health, and American quarantine, and to look through your lens at quarantine, one of the most primitive and universal instruments of defense against contagious disease epidemics. You write in the acknowledgments of your book that you spent 18 years doing the research, which takes us back to about 2003. But you also have told me that when you were in the 4th grade, you went into the school library and read everything you could find around the American Revolution. So I think we can trace this book back a little bit further than 2003. So I thought as an entree point into this, that you could tell us a little bit about the process of your research. And of course, I have to ask you, did you ever think that you would be publishing this book in the middle of a global pandemic?
Well, initially, no. I had no idea that this would be coming out in the middle of a pandemic, let alone an epidemic. But as I got into my research, I began to see that epidemics and pandemics were happening more often, and that finding the time to release this book might actually not be too difficult to coincide with the next pandemic. In fact, coincidentally, last February, late February, I had an inkling that was something happening. So I decided to take my manuscript with me, went south, and spent several months on a quarantine island. It was an island, but in de facto, it was a quarantine island for my purposes, and brushed up and finished the manuscript and submitted it. And that really was kind of an amazing thing, because there historically were people who said, well, you know what, who's interested in quarantine? It just doesn't happen that often. And they had a point. They had a very good point, but they didn't know about COVID-19. And so that really, that had a lot to do with how I expedited getting this thing ready. Even though it was ready, it needed to be brushed up a little bit to tie it into COVID-19 and tell that story with a little bit of a slant to that issue. But, you know, to the point about my fourth grade reading habits, yes, I did read pretty much everything in my fourth grade library, although I will say there wasn't a lot there. So probably about 4 or 5 books into it, I realized I needed to do some more research. And of course, that took another 40, 50 years to realize that I was still working on the same basic project. It was a long haul. I mean, it really was 18 years of research, and it was, I'd say, over 50,000 documents that I ended up going and reviewing and compiling. And if you see the book, you'll notice how heavily footnoted it is, because one of the things that came out of the process after having a number of peer reviews, the academics, of course, love footnotes. That's one of their cause célèbre. They think a footnote really adds value. Well, my big challenge was to put the footnotes in, but keep it to read like a novel and have characters that could speak about the history to people like Paul Revere or Samuel Durgan, who we maybe never heard about, but who was a very famous and important 19th, early 20th century public health figure in American Public Health Association. So I took, you know, the grist for the mill that you get from the academic world and made sure I polished the book so it was readable, despite the intense footnoting that the academics like. So the best of both worlds in some respects.
Well, speaking of Paul Revere, listen, my children, and you shall hear of the midnight ride of Paul Revere on the 18th of April in 75. Hardly a man is now alive who remembers that famous day and year. We're all familiar with this Paul Revere and seeing him with his cape flying. We all, I know, at least when I was in school, we all studied Paul Revere, but you write about Paul Revere in a very different role. So perhaps you can tell us about Paul Revere as the public health person.
Yeah, I will tell you this, that Longfellow poem, which you're talking about, has no similarity to the Paul Revere of the late 18th century, early 19th century. Of course, it did have a certain cachet because here he was, he and William Dawes, the two guys on the horses, and Dawes got left out by Longfellow. But in any case, Paul Revere was probably the most important quarantine public health figure in New England history. He was the president of the Board of Health from 1799 to 1802. And in that period of time, it was the first Board of Health in Boston and only one of 4 boards of health in the United States. All politics were local back in that century. There were no state boards of health. There's no federal health system in place. So it all started in that local area. And Paul Revere really was one of the great leaders. He was a man who had the charisma, not only because here he was, the guy who rode the horse and so-called saved the day for those Lexington Minutemen, but it was more than that. He actually understood the politics of dealing with epidemics. He understood how to deal with the business world because he was a business person. He was a silversmith. He was a merchant. He was a craftsman. So he appealed to those various groups. And one of his first acts in becoming the president of the Board of Health was to issue orders to clean up Boston, because Boston was not exactly what you might expect to see today. People would throw dead dogs and animals out in the streets, and that was accepted behavior. So his first job was, let's clean up our act here. Let's clean up Boston. And let's also at the same time impose quarantine. In those days, quarantine was a matter of fact. It was a part of the routine of life. It was such a routine in that 25% of the entire 18th century was under quarantine orders in Boston. That's how an enormous portion of the time was involved with the quarantine world in that period of time. And he had the skill to be able to get the merchant class, who obviously would run for the hills when it comes to quarantine. He got them to accept it and to deal with it in a way which probably no other person could have done. He was an amazing figure in that regard. And really what my book does is tell an entirely new story about a man that everyone thought they understood, and turns out to be an extremely important public health figure in American history.
Yeah. So quarantine, which is a noun, is a place of isolation or physical separation, and as a verb, to impose isolation on individuals or livestock. We have the major port cities of Boston, New York, and Baltimore, and then Philadelphia, are cities where there were major outbreaks of diseases and where there was quarantine, where people were housed. Perhaps you can talk about that a little bit, Charles.
Yeah, I mean, back in the 18th century, early 19th century, cities ran the world, a little bit like in the Medici period in Italy. They were all city-states. State governments were very small. So all of the public health in America started with Philadelphia, Baltimore, then New York, and then Boston in that order. Between 1794 and 1799, they all created boards of health. And basically, the fundamental purpose behind those boards of health was twofold: sanitation and quarantine. And quarantine was considered to be one of the most important parts of it, because so much of the 18th century was a period of smallpox, in which virtually every 12 years, you can almost set your clock by it. In 18th century Boston, almost every 12 years, there was another epidemic. And it was you could call it a seasoning that went on. The young people were the most susceptible. The older people, if they were still alive, had already had the disease and had survived. And so you had those diseases driving the concept of quarantine. Because if you know what quarantine looked like, with the pustules and the rawness of what it did to people's faces and to their bodies, and just confluent smallpox, which basically meant people were entirely encrusted in pustules, was so horrid that it drew people to impose quarantine in a way that today people would not fully understand. It was just that horrid. And so quarantine was really driven by the disease smallpox, but to some extent, it was also driven by the fact that a lot of diseases were not fully understood in that period of time. Not to say that they're understood today. Believe me, there's a lot of unknowns even today. But then there was really very little understanding of what disease, how diseases happened. And I call it the holy grail of disease transmission. How is it that disease gets transmitted from one person to another? No one had a clue, not even for smallpox. They had a clue, and then they didn't have a clue. Then they'd have a clue again. There was a great deal of going back and forth on some things which are the most obvious, but obvious is all in 2020 hindsight. Those four port cities were significant in developing American public health practice that then, of course, later on became institutionalized by states absorbing that function or trying to play a more dominant role beyond that of those little city states that we had.
So they really couldn't tell which diseases were communicable and which were not, because.
Yes.
So the term basic reproductive number is used to describe the communicability of a disease. What does that mean, and how is it relevant to stopping an epidemic?
Well, that's a term, that epidemiologists use in the public health world. A basic reproductive number is just how quickly something reproduces. You could apply it to your bank account as to your interest rates. That's like a reproductive number on interest rates. It could be applied in terms of population. What's the reproductive number of a whole population? But in the field of disease, it's how quickly a disease is transmitted. And that is, to a large extent, while there'll be an incredible amount of modeling and science, so-called science going behind it, it's really a cultural artifact that's determined by a number of factors. One of the factors is how dense your population is. If you live in Hong Kong, where the density of people per square mile is in the order of 20 to 30 to 40,000 per, even some areas per acre. But if the density is in a rural area of Montana, your spread is going to be different. But it's also not just a question of density, it's also a question of human behavior. You've probably heard the expression, the super spreaders. What I call certain people who are really have a PhD in coughing, professionals. They know how to cough the furthest distance. There are amateurs out there who don't go too far, but the professional coughers and sneezers, they can do more than 10 other people combined. So when you're looking at a basic reproductive number, you're looking at almost like averaging every bank account and how everybody's interest rate works. And maybe they're variable, but in the realm of public health, because of the variability of how people perform in terms of communicating disease, the average does not necessarily mean what any given individual's performance will be. Some people are really good at this. Some people can cough and sneeze and go 20 to 25 feet. The average person might only do 8 or 9 feet. CDC, of course, uses a 6-foot distance, a little short actually for looking at things. But if you're looking at the law of averages, well, I guess it's okay. But when you're looking at a bell curve of performance, there's the LeBron James of the coughing world, the professionals who know how to do it from a long distance. So those are important things that influence the basic reproductive number. And there's a variety of other factors, including the immunocompromised state of the population, comorbidities that may exist within the population. People who have diabetes, for example, are more likely to be susceptible because their immune system is compromised. So there's a whole host of issues that go into establishing it. But the key thing to understand is a basic reproductive number is a speculative term until an epidemic is over. Once it's over, then you can say, well, what really happened? During an epidemic, nobody really knows. And you've seen it in the curves for COVID-19, up and down, up and down. And those things vary because of the interventions that are being done by every level of government and private sector.
What more do we need to learn, Charles, about how diseases are transmitted?
Well, in terms of what we need to learn, first of all, there's many different ways that a disease can be communicated. You have through ingestion, which is an example of contaminated food. That might be like the case of typhoid Mary, or it could be cholera with contaminated water. You have the case of AIDS, where it can be a sexually transmitted disease. You have the case of smallpox, where it can be dermal or even inhalational based. And you have anthrax, which could be either inhalational based or dermal based. So each disease has its own method of a transmission. And for that reason, no, there's not one size fits all. Now, in the 18th and 19th century, yes, one size fits all. Throw them in the pen, hold them there, and see if they live or die. That was the 18th century. Over the last 200 years, we've gotten sophisticated. Well, is it a communicable disease through sex? Is it a communicable disease because we've inhaled somebody else's viral particles from COVID-19? What is it? And then, of course, the countermeasure is based upon that, what I call the holy grail of disease transmission, which is the method. For example, in COVID-19, when you know nothing, people say, try everything. So we know it's an inhalational disease. And yet, of course, you'll see people say, well, let's wash our hands. Let's do all of these other things. Well, there's nothing wrong with washing your hands, but I've yet to see anyone get COVID-19, and I haven't seen any studies yet that have proved that hand contact has been the means of transmission. It certainly doesn't hurt you, but we know it's an inhalational disease. So these are the things that go into it. And even today, we have diseases which have, over the last 15, 20 years, thought to have been cancer, and then turned out to be communicable disease. The human papilloma virus is an example of these things. And there are other diseases that are sexual in nature, which have been endemic in our society, only because no one understood how they were transmitted.
So when I started reading your book, I was curious about how the pandemic of 1917, the Spanish flu, and of course we know the Spanish flu didn't start in Spain, but that's another story. And so I called the New Hampshire Historical Society. I thought with all the mills in New Hampshire and people working close to one another, and talked to this lovely archivist, and she said, I'll get back to you at the end of the day. And I expected to have her call me with this list of books. And she got back to me at the end of the day and said, I'm sorry, we really don't have any information. And what I recommend is that you go to local libraries and local newspapers, which of course made sense. They would have some of the information. But I understand when we talked with Tom and knew that we were going to do this program, Charles, that you have made a discovery at the Portsmouth Athenaeum that members you found something that in all your years of research, you hadn't found. So why don't you share that with everyone?
Yes, I did a little deep dive, Tom, on your Athenaeum's literature online. And I've got to say, after doing 18 years of deep diving, and I've gone to libraries all over the world, I've gone to at least 40, 50 libraries. I can count 50, and beyond that, who knows? And probably about 4 or 5 continents of research. I have yet to find anybody who had a complete list of everyone inoculated for smallpox in the late 18th century in Portsmouth. And you have this on your website. It's a unique document. I've never seen such a thing anywhere else. And personally, I consider it priceless. But separate from that, there was a masterful letter that someone named Hall Jackson, who was a famous 18th century physician in Boston, who actually was one of the discoverers of digitalis, which was really used for a cure at that period of time. But more importantly, in this letter, he wrote to Elbridge Gerry, who you might know for other reasons. All of you have heard about gerrymandering. That's where either the Democrats are trying to control the Republicans, or the Republicans are controlling the Democrats by rewiring the lines of congressional districts. Well, this letter was sent to Elbridge Gerry, telling him about the challenges of getting people inoculated in 1775, just as the Revolutionary War was happening. And he said, in his personal estimation, he didn't think there was much hope that the military was going to get their act together, because he didn't think many of them were even going to take the inoculation. They dreaded it so much that they thought that this would be the end of us and the war would be over and we'd still be under the King of England. So this letter is in your archives, and I actually just transcribed it today just to make sure I understood what it said. It's a masterful document, and it's one of the few letters that I've seen that gave a firsthand account of public sensibilities about the use of inoculation. It was a dreaded concept for many people because it was giving them the disease, but in an attenuated form. So, Tom, I think you've got some great stuff there, and I'm impressed with what I've seen in your Athenaeum.
Thank you, and that you can get it from Connecticut.
I can get it from Connecticut?
that you can get access to our documents.
Oh, yes, of course. Well, that's the wonders of the internet, of course.
And Charles, you were saying you thought it would be, it might be good to blow up that list of people that you thought you could kind of see it as a poster.
Oh, yeah. Tom, I would highly recommend it. I would take that. It's 9 pages of data. I noticed. I think I'm going to buy a copy myself if I can. But I would say it would be a wonderful poster to put in the Athenaeum because it gives the details of what the doctor actually did. And it's like for each individual, and of course, today it would be under the privacy laws of the federal government. You can never see the darn thing. But back then, who cared? But I'd say it really is worth putting up. It's a great document. It's a unique document. So that would be my recommendation.
Thank you very much.
So, Charles, why is there so little? I know there's literature about public health, but there's very little literature about quarantine. I mean, why is that?
Well, there's a couple of reasons. One is I can tell you that the 18 years I spent was because the data is not easily accessible. I had to go and review every single newspaper that was ever published in Boston. And also I did the same thing in other cities like Philadelphia, year by year, day by day, or if it was not daily, it was a weekly paper, to go through to piece together what went on. And likewise, the same thing going through the selectmen minutes for the town of Boston from the early 1700s onward. I mean, I don't know of very many places like Boston where the record keeping was so detailed. And yet nobody has yet pulled that primary source data together. So part of it is that the data is very difficult to get. I had a page or even a paragraph in some of the chapters that I might have spent 6 months just to be able to write one paragraph about the one I just mentioned earlier, the 25 years that the entire Boston was under quarantine in that century. 25 years, that means every 4th year, people were under these epidemic quarantine conditions. Well, it took an enormous amount of time to get it. That's one reason. The second reason is the more obvious, that as soon as quarantine is over, everybody runs for the hills and wants to return to normal. And who gives a hoot about quarantine? I mean, only someone crazy as myself would have done such a thing. But the reality is, having been involved with the anthrax response team back in 2001 and 2002 with a team of other people, Jim Gaffney, who was one of my colleagues, was one of the great supporters. We worked on something which we realized that when you get involved with something in that depth, in that personal way, it gives you a focus, it gives you a mission. And so for what others might not have thought to be interesting, to me was one of the most fascinating things. And as I kept on looking into the records, I found some of the most amazing activities that went on in quarantine islands in the United States. I couldn't imagine. I mean, there were people that ran these islands as if they were their own little kingdoms. And the people that were quarantined there were not under any government. They were under the quarantine master of that island. At that time, they were called island keepers. Then they became port physicians later on. And these people, these men, had such power, and nobody even realized it because they were miles offshore in another kingdom. And as a result, these little hidden gems, which nobody has ever bothered to look for, were revealed. And most of the stuff I found was unpublished material, unpublished diaries, unpublished minutes of the Board of Health. This is what gave me the grist for the mill to tell a story through the eyes of these people, not through an abstract lens, but through the eyes of these individuals and how they saw those events, through the eyes of the island keeper and how they thought about these things.
So you suggest that that's what needed, Charles, and what worked looking back historically. And of course, it's history that explains the present, is a triage of skills. resources and public support based on transparency of government and public trust. What are the leadership skills required of political leaders and public health officials?
Well, that's a question of interest, I would say, today. I think we've gone through a few little hiccups in the last few months and years. One of the things that you'll find historically, there has been a constant tension between those who are trying to save lives and those who are trying to save the economy. This is an ongoing battle that's been going on from time out of mind. This is not a new thing. But one of the key elements of where it's worked well, we've had quarantine, which has been a disaster. The 1819 epidemic of yellow fever in Boston, which was one of the low points of quarantine in world history, in my opinion. And then we had the high points, places where there was collaboration. In 1764, where the governor, along with the first selectmen, the physicians, and even the merchants all banded together in the interest of working together to solve a problem. And the key was understanding that the medical profession or the public health people later on, whichever happened to be in the lead, were given primacy to do their work. When the decisions have been made by politicians without informed views from the public health and the physicians of that time, we've always had problems. In 1872, probably one of the most remarkable things happened. We had the most highly politicized public health department in the United States from about 1822 to 1872 in Boston. It was so political that the politicians said, well, who cares? These people, it doesn't really matter what happens. They're all poor people, they're Irish, so what? And of course, it got to a point where the Irish decided they had enough, and they drew the line, and they had protests in Boston, and it was so powerful a movement against the do-nothing politicians that they voted them all out of office, and they created a board of health that was independent of the politics. Yes, they had to get the money from the political leaders, but they were once again restored to the level of trust that Paul Revere had some 72 years earlier. They had lost that message only because, some disasters in 1819 kind of set the wrong tone. So really the key is, if we're in a capitalist society, yes, let them all die. But if we're in a society in which we care about our communities, our families, our neighborhood, and indeed today the neighborhood is not a small neighborhood, it's the entire world, then we are only as good as the weakest link of that entire network. And that may be somebody who's living in South Africa, or it may be somebody in Brazil, because the entire system is so networked. So now the key is developing a recognition of the independent need, independent voice of the public health function. This is something that can never be fixed finally, because there's always going to be that tension. But how far it goes in one way or the other is going to be the challenge. If you go entirely to, it's all a big game and let's not worry about death, well, you've gone one too far the other way. If you go the other way, in which life is the only thing that matters, and be gone with all industry and commerce, obviously that's the other extreme. The balance is, how do you achieve a mitigation strategy which accomplishes the most with the least impact? And what I call it is the Pied Piper effect. For those who know what the Pied Piper is, he's that person who led the plague village of Germany out of the plague in the 13th, 14th century. It was a masterful person who had the charisma to lead people through the heart and through the mind, through both the rational faculty, the emotional faculty, and for the greater good. That concept of greater good is something that we have to restore in our society. It was very strong in the 18th century, but we've lost some of it. And understanding that greater good is central to understanding the conflict between the public health function and the capitalist view of keep the economy going. Even the best capitalists recognize that without workers, they're not going to be going forward. So this is an art form, but the art form requires a diplomacy which shows that both values are important and both have to work in congruity.
So in your chapter called Redefining Quarantine for the 21st Century, you discuss four quadrants: quarantine, surveillance, self-tether, and woo-wee. Perhaps you can describe these quadrants to us so we can understand them.
Yeah, I'm glad you mentioned that. That's one of my favorite little quadrants for all of those who like drawing boxes. It's a Montessori thing, you know, you draw 4 squares and what's in the 4 squares. Well, the book is about quarantine, but really when you're getting down to where we are today, our governments are incapable of applying quarantine in a world as large as we are. Quarantine made sense in the way it traditionally handled when you had very small villages, you had a couple islands, you could put everybody out there and say, okay, all the diseases out on the islands, you're fine. But in the world today, 2 things have happened. One is we've become so networked that we're all interconnected. And so the burden has shifted from centralized control over people with disease to the second component is a surveillance program. Part of this had to do with antibiotics and antivirals. Once those are available, if you have an antibiotic, you don't necessarily need to put somebody into quarantine. They just need to take their medicine. So there's a surveillance component. That's step 2. And it also is a case in surveillance where somebody may have a disease, but we don't know for sure. So you don't put them into quarantine. You just have to have a surveillance program to make sure that nothing manifests itself in the form of disease. The third phase in which I consider we're in today is the self-tethering. Everybody is on a long leash in COVID-19. Some are on a short leash. Some are not even on a leash. They're actually off and gallivanting and doing whatever they think is in their own best interest. That self-tethering concept is not what quarantine historically was about. Self-tethering is a sense of self-responsibility. Self-tethering you can associate with the common cold in some ways. Well, yeah, I'm not going to go to work because, you know, it's just a common cold and I better be mindful of not spreading it in the office. And of course, there are plenty of people who don't follow that rule, but for those who do, that would be self-tethering. Then that's basically the idea that the government is not incapable of handling the situation. That's what's happening today. COVID-19 is well beyond governmental abilities to do anything to control it. So they say, pretty please, I would like you all to stay home and do this. Pretty please, pretty please. You know, there's the person who gets arrested for not following self-quarantine really had to go out of their way to get caught because it's so difficult to get caught in this system. So the 4th category is wu-wei, and that's what I call wu-wei means is action in action. It means it's the kind of disease in which you got something, but really the consequences are innocuous. It's a little bit like the common cold without any transmission, or something which really adds nothing more to the communal disease burden. And as a result, it really falls into something which is almost inconsequential or not even noticed. And yet that kind of disease through mutation at some point could become the common cold. And that same common cold through mutation could become COVID-19. And so you always have to watch the migration pattern of disease, whether it's a virus or a bacteria, because they may switch where they are in terms of how we need to respond to them.
So in the early 19th century, the US Public Health Service revolutionized medical inspections for immigrants arriving here when it installed American physicians in every single country, so they could actually test people before they came. So this novel initiative had a major impact on global public health. And to Americans in particular, what are the implications for today's world?
Well, I'm glad you mentioned that. It's probably one of the most revolutionary developments in American and world public health history. A lot of people don't know that from about 1880s through the 1940s, before World War II, basically, the American public health system, it was a US Public Health Service, began putting its medical professionals in the major embassies of the world, primarily those places where there's an enormous amount of immigration to America, the European countries, Italy, Germany, France, England, and of course some Asian countries as well. And what ended up happening was, instead of quarantine being the last straw, the last wall in stopping disease, which it was for the last, call it 400 or 500 years, because everyone would come into the quarantine islands, of which there were 66 along the eastern seaboard and the Gulf coast. They'd come in to those quarantine islands, and if you got it and stopped it, great. If they snuck through because they were asymptomatic, well, there you go. One more epidemic down and into the American world is another thing happening. But what they decided to do was, let's switch the game. We'll have everybody inspected overseas before they get on the boats, make sure they're healthy, so that when they come to the quarantine islands, they are actually likely to be in pretty good shape. And if they miss one or two, well, then they would have got during that boat ride, which is usually back in the 1900s, several weeks to several months, the disease probably would have manifested. But in the 19th and early 20th century, that was a revolutionary development. And what it ended up doing is virtually eliminating most serious communicable diseases from coming into the United States. And yet here's the tragedy. That whole development basically was stopped in 1945, right at the end of World War II. And they threw out the whole idea of health certificates and bills of health for all of the boats that were coming into the United States, and said, look, everything looks so good, we don't need it anymore. So here it is, 1945, let's just keep on counting. It's about 75 years later, here we are today, and dealing with the same issues, and now reinventing what we had before. The thought that is now emerging: should we have vaccination certificates worldwide when people travel? Should we have some immunity passports or things of that nature? Well, those were the things that were developed over about a 50-year period by American public health professionals. And what was interesting about this was that this then changed the public health of the European nations, when they said, oh my God, the Americans are making us clean up our act. What are we going to do? Well, all of a sudden, the Europeans started cleaning up and paying attention to public health. They weren't just exporting their people to America. They realized that, well, there's a little bit of handwriting here going on. If they expect our people to be healthy when they come over, well, maybe there's something we should be doing ourselves. And that was a very significant transformation of public health on a world scale.
Well, and of course, now we can see with globalization in the 1990s, I mean, there's so much movement and everything is so interconnected. It would be kind of impossible to even probably think about how we would do that. People aren't coming on ships. They're, just going from airport to airport to airport. So it seems like, it would be much more difficult to think about what we might do that would be kind of one size that would fit all. And what are the prospects for developing kind of a multinational, multi-global, epidemic response teams that can, monitor what's going on so that we have an idea and we could stop things when they start?
Well, that's a huge part of what needs to happen here. It's really the wake-up call for the next 40 years that we're going to have to be working on rapid response epidemic teams, or epidemic intelligence service is what the public health service used to call it, and CDC had it. And the only difference is that CDC did it as an American venture. What we need is a multinational epidemic intelligence team that is a cadre of individuals who are on 24/7 watch, just like the missile deployment program that we had for the Russians. The Russians had their missiles pointed at us, and we had ours pointed to them, and we had 24/7 readiness for any event that might destroy the world. Well, you know what? This is the same kind of level of concern that really needs to be put to it. That the possibilities for more rapid communication of disease has never been greater. I mean, we can go right now from New York to New Zealand in roughly, if you haven't done it lately, neither have I, but it's about 20 hours, they say, if you're taking the flight. I'll tell you what, you couldn't even fly across the Atlantic in 1930. It took until the end of World War II that they have a plane that goes across the Atlantic, really, aside from Lindbergh doing a one-off type of thing. We did not have that level of interconnectivity and communication. And really, this is the fault of the CDC and Public Health Service in thinking that everything is grand. We have no more disease. And so there's no need to start looking at these issues. So really what's going to happen is that there's no question that the Epidemic Intelligence Service has to happen. Whether it happens under the World Health Organization, which would be the ideal way to do it, or as another independent body, these things are already emerging. The question is, who's going to stand up and raise their right hand and say, yes, I agree, you can come into my country and do what you want to do and get it done quick. Now, try to convince that to the Chinese. But the reality is, that's what we need. We need these countries to raise their right hand and say, we're going to do it. This is a key thing. Instead of, well, we're just going to get in here and hide our little problem because this is what's been going on. And if you think China is a new thing, this has been going on for hundreds of years. Nobody's ever tried to tell the truth about what's going on in their home port. It's always, well, things are just fine, because that's the way business operated. Nobody wants to tell you that anything was in bad shape. If you read all the newspapers from time out of mind back to 1700s, rarely would you ever find stories that were talking about how bad things are. Commerce was, of course, a big supporter of the newspapers, so they always had to keep to the party line in that regard. So yes, we do need to do something about this. This is really a major step that we have to do. I've said in the book, and you read the last chapter, read nothing else in the book, read the last chapter, because the last chapter basically says, we need to get our act together on this, and we need to focus on things that can be done to stop disease, not just to respond to disease. The responding part is like all of the Rambos of the world, of which I probably set in on some of that Rambo activity. But the other part of disease is not just responding to it, but preventing it from beginning in the first place, creating a world environment in which we're not enabling zoonotic disease. Zoonotic disease is the transmission from animals to human. And that is one of the most significant means in which we've had disease transmission and epidemics and mortality. And the answer to that has a lot to do with climate change, has a lot to do with the actual deforestation of the world, the overpopulation. There's a lot of factors that tie into creating the environment, the atmosphere in which disease does not breed. See, that's going to be the challenge here. And of course, I do say the American Public Health Association has to do an assessment of these issues. Of course, it goes beyond them. it goes to the big guys on the top here, both at our government and all governments, if they're going to take it seriously. Because what we do have is many sanitary conventions over the last 150 years. Sanitary conventions are where everyone again raises their right hand and says, we're all going to work together to try to solve certain disease problems. But they've been more lax than they have been rigorous. And some of this is going to have to change.
So I was just saying, for some of you who joined the call early, that it's exactly 1 year ago this evening, March 11th, that I had theater tickets for that evening, and it was closed. I got an email in the middle of the afternoon that the performance was not going to go on. And then the next day is when New York shut down. I'm in Manhattan. And so I only wish, Charles, that we had had your book a year before, and that we could have been having this conversation so that people would have a better sense of how to handle what is happening. So I think we're getting close to 6:30. So I wanted to give all of you an opportunity to ask a question or join us. I notice there's one in the chat here. Would anyone like to ask a question?
I have a question. I'm wondering if there's anywhere that you feel Charles did quarantine right in the past year.
Well, doing it right in the past year, well, I'd say there's obviously there was a story, and I think today's New York Times, about Seattle doing a relatively good job in what went on. I would say overall that the New England states tended to be more proactive and diligent about the face mask and social distancing strategies than some of our Midwest states. And I think there were some significant errors that were made in terms of understanding the nature of the disease and the vulnerabilities of nursing homes in particular. And at one point we all thought that the state of New York had done a great job, but as things have leaked out, we've learned that a lot of the nursing home mortality was underreported. If you probably read about that. So I would say, the states in New England overall have done a relatively good job. In fact, I'd say Maine in particular has had some very good policies. But the actual what makes something effective is not simply the fact that a governor issues an executive order. It's also the behavior of the people within that society, that community. And I'd say that the New Englanders overall have done extremely well in terms of the response to it. Not that the mortality records necessarily always reflect that, but I think that in terms of the commitment to social distancing and wearing face masks, there's the states that have actually done the most. And of course, some of the Western states like Oregon, Washington, and California have also done a commendable job as well. One of the problems I will tell you is that I've downloaded almost 2,600 executive orders from all the 50 states, Puerto Rico, DC, whoever's involved in the American experience. And that by itself is a disaster. If you're trying to, it's like trying to educate people with a fire hose of information. Nobody in their right mind has read all of these executive orders. And so in many ways, those who've kept it simple but direct, and constantly repeating messages of social distancing, face masks, and considering other practices when in the public or in private settings, those are the ones who I think who have done the best. And so you're going to find on the individual level, there are people like that throughout the country. But if you look at a more broad brush level, the proportion of those people, I think, is largely in the Northeast of the United States, although it has changed to some extent in the rest of the country as they got hit extremely hard. So if you look at any one of them, you know, the ones, they've all learned. The question is, did they know from the Getty up, or did they learn after 2 strikes or 3 strikes? And so the thing that I think is that a few of them have struck out, and those are the ones that I've noticed that didn't quite get the message about CDC actually having something useful to say, as in the last couple of weeks. So it is a challenge. It is a challenge because you know, everybody's fine line of public health versus economics, you know, is kind of the oddity. But really, you know, it's example is better than precept, obviously, but precept is necessary in a time like this, especially when nobody's ever had precepts like this before. For those who don't know, there's never been a state level or national level face mask requirement in this country. Even in 1917, when it was done, it was only done by a few towns or cities on a helter-skelter basis. So obviously, this is a giant learning experience for all of us.
There's another question. Do you think that there will be a requirement for universal vaccination when we travel? That in order, you know, that we'll all have to have proof of this vaccination?
I think it makes sense, you know, from the point of view of public health, to do it. I mean, that's what we used to do. If any of you used to travel back in the 50s or 60s, you had a yellow card. They gave you your vaccination. I've traveled all over the world and I've lived all over the world. And I remember carrying that vaccination card that said, yes, I've got the yellow fever, you know, vaccination. I had other vaccinations for whatever it is. Honestly, unless everyone gets vaccinated really quick, and I don't see that happening on a world scale, there's a lot of merit to the concept.
Well, if there aren't other questions, go ahead, Carmen.
Yes, Elizabeth and Charles. I'm just wondering, and this is a little bit vague because I read things and I don't remember the details, but there was an account where bats in China were said to transmit disease through various animals, and that was how COVID happened. If this happens, I don't see how we can control all the bat population and all the animal vectors to eliminate this kind of disease. So I wonder how you think it can be done.
Well, that's a very good point. When it gets down to the bat is one thought of where it was, but these were coming from wet markets. At least that's the most likely scenario. Wet markets is where you have people who are buying live animals and selling them under uncontrolled conditions. And the pangolin was really thought to be the source of it. And of course, right now there's talk about that the pangolin was only an intermediary animal in the process coming from the bat. But the reality is it's the wet markets that have done it. And similarly with what's going on with eating bushmeat in Africa, which is the Ebola crisis, we have the same basic problem, in which really we have a world in which we're heavily destroying the wilderness areas of the world, and at the same time putting people in close contact with animals that have never really been in touch with humans on a much more routine basis. And that is where the transmission occurs. But the wet markets in particular are it. Let's face it, that, you know, if you're looking at the 4 horsemen of the apocalypse, of which pestilence is one of the 4 horses, none of those 4 horses are going to disappear. The question is whether we can minimize the apocalypse that happens by pestilence. And that is a question of minimizing how much we interfere with the food chains with the animal world in making it less of a interconnected disease transmission process. And we're enabling disease in a way that had never been seen before. So it's not like we're going to stop this thing, but we can sure step out of it and do the right thing. I mean, you can always step across a highway and look neither which way and get run over, or you can look both ways and maybe you'll make it across the street. And I think a little common sense here, but also has a lot to do with thinking about the world planetary diet and what we need to do given what's happening. So it's not just a issue of confluence of humans and other wild species, but it's also a question of our connectivity with animals that have never routinely been part of our habitat.
Thank you.
What is your assessment of the current administration's approach? And do you feel that it's anything more than just a reactive approach, but will they incorporate some of the ideas that you've talked about in further prevention?
And could you clarify on that, on the further prevention concept?
Of recognition that this may not be the only pandemic and that we have to be in a state of continual preparedness.
Yes, that is going to be something that, well, the proof will be in the pudding. It's easy to say because I know back when I was in the government, we had the pandemic response plans for the next, the flu pandemic, 2008, 2009, and everybody planned for it. Well, those documents are, getting a lot of dust on them at the present time, and they certainly weren't being reactivated by the previous administration and are totally irrelevant at this point to the current administration. The proof will be in the pudding. I do know that this administration is aware of these issues. The question is how much funding will go into that particular initiative. And I think since they only passed the law like a day or so ago, and I guess Biden is signing it on Friday, we're going to have to do a deep dive on the amount of 1.9 trillion and see how much of it is actually allocated for things of that kind. I do think, though, that we've never had a pandemic of this nature, going back to 1917. That's 104 years ago. So hopefully there will be some things going on. But even if the government doesn't do it, I will tell you, major corporations right now are heavily invested, including Bill and Melinda Gates and a number of other major benefactors in looking at this very issue. It's a little bit like in the 18th century, the East India Trading Company was in some ways bigger than the United Kingdom as a government. And we're finding that today, that if you take the 20 wealthiest people in the world, they have more wealth than I can't even tell you how many countries have less wealth than the top 20 world billionaires. And so these are the powerhouses of the future, those philanthropists. And to some extent, that's what's going to drive it in part. But obviously, the federal government has to play its role.
You have time for another question?
We have one more question.
Yeah, I have a question. Charlie, do you think that the progress has been made theoretically in fighting these situations, but at the same time, population has grown fantastically? So do you think that the density of population increasing density of population will prevent ever achieving a success over these things or not? Will the population continue to overcome man's efforts?
I think that's about as great a question as one can ever ask. I mean, I've wondered that myself. I mean, it's the issue of, we had 7 billion people in the year, I guess it was 6 billion in the year 2000, and we're, approaching 7.5, 8 billion people already. It's supposed to, depending upon the rate that we go at, it's either going to go to 9 to 11 billion people by the year 2050. And if that's the case, the only hope for mitigating disease transmission is establishing urban environments or even environments that are not necessarily urban, but are based upon a different relationship with the land. We're consuming too much land, and we're failing to recognize the value of that land that exists, which we may not think has value, but ultimately it's what's holding this earth together. It's holding the other animal systems in place, the other ecosystems in place. I mean, in terms of climate change, without the various forest systems, we're looking at increasing temperature changes. So I don't know if we're going to be able to do it without some radical changes. It's almost a Malthusian question you're asking. Malthusian is like, when do you get to a point where your population crashes because the food supply just doesn't meet what the population needs? And there's a good shot that we're going to be dealing with that, because there's whole continents that may be wiped off the map, including much of Africa, parts of South America, even Asia, where the temperatures will be so great and the populations will have to migrate from there because it will not be possible to live in those environments. So we're getting to a point where whether we do anything or not, Mother Nature is going to force our hand, and we're going to see some very significant issues. And I think we're already beginning to see it. I will tell you, Biff, one of the things I see, these storms that are coming in now, we get hurricane force winter storms. Nobody's calling it a hurricane, but the winds are over 75 miles an hour in some of these transitions from hot to cold zones, where the warm front comes in and the cold front is behind it, or the other way around. The winds are so strong, we're seeing enormous destruction of the forest systems. As the winds get stronger, these will even be worse. So I see some things are going to have to change. I just don't know which is going to be the most significant change agent. The decline in population, which I hope would be everyone would have to raise their right hand and say enough is enough. One kid's enough. That's what the Chinese did. But nobody likes to be told that. So how do we do that? It's going to be, it's either that or the draconian Malthusian approach, which is the survival of those who actually have enough to pandemic, or the next major drought, one of the other four horsemen of the apocalypse.
So I like to always, when I'm interviewing and in conversation with an author, read something from the book. So I just want to end with one paragraph. We now find the most lethal diseases emerging from ecosystem disruptions, where humans have adversely impacted other forms of life. Coming into contact with novel species, they are indeed biting us back, whether it is for survival or convenience. In the last resort, quarantine is not a solution to the next pandemic, but a symptom of the ecological imbalances we have created that leave our species more vulnerable to pestilence than it ever has been before. So I think Charles, I would love to have you in conversation with Dr. Fauci. And certainly it would be very nice to have a conversation around climate change as well, and how all, this could be a series, actually.
Yeah, it could be more than a series. It could be a lifetime pursuit.
Absolutely.
So I really appreciate this. After putting 18 years into it, it's very close to my heart, some of these issues. And obviously it's close to all of your hearts, in that you're all living through the same thing I'm living through. And I hope that we can get through it shortly. It does look very optimistic at the moment. But if the past be a guide to the future, the story isn't over yet, and the game is not over yet. The movie is not yet, over and that lights are not yet turned on. So we have to be somewhat mindful because things of this nature, like viruses, are ever so capable of mutating very, very quickly. We look at a generation and it's 25 years. For a virus, it's a matter of minutes or seconds. So it's really a question of being humble and recognizing that things may happen that are not totally in our control.
Thank you, Charles, and thank you, Tom, for having us. It's really been a pleasure.
Thank you both. It was an outstanding discussion.
Thank you.
Good night, all.
Okay, Tom.
Night. Thank
so
you.
much.
Hi, thank you.
Enjoyed it very much.
Thank you.